Hi, everybody. This is Professor Wells, and we're going to go over Chapter 7, Preventive and Desensitizing Materials. The dental assistant or hygienist is often asked by the dentist to dispense, apply, or fabricate devices such as fluoride trays or bleaching trays, and to deliver these preventive aids or devices to the patient. Fluoride may be found in well water and food that has absorbed fluoride from the soil and is an additive in many dental products that we buy over the counter. Fluoride is one of the greatest public health successes of the 20th century. The accepted optimal level of fluoride in the drinking water is a range of 0.7 to 1.2 parts per million. Consumption of excess fluoride during formation of the teeth may lead to a condition known as fluorosis. Severe fluorosis can cause brown staining and pitting of the enamel surface. This is also called mottled enamel. Mild or moderate fluorosis can create opaque white spots or bands on the teeth. Eating fluoridated toothpaste or swallowing supplemental fluoride during dental treatment could cause fluorosis. This is a figure that shows pretty severe fluorosis, and please make note of the enamel defects and discolorations. The enamel and dentin of the tooth are composed of tiny mineral crystals called hydroxyapatite. The tooth crystals are not pure hydroxyapatite, but they contain carbonate, which makes them more soluble in acid. When the bacteria and plaque on the tooth surface metabolize cooked starches or sugars, they produce acids. The acids remove more mineral, causing demineralization, than the amount of mineral coming into the tooth from the saliva. The surface becomes more porous over time, and this allows bacteria to enter the tooth. Ingested fluoride that enters the developing tooth bud can come from the drinking water, foods, beverages, or fluoride supplements prescribed by the dentist or the pediatrician. Fluoride in the saliva surrounding the teeth is incorporated into the surface of the enamel crystals during remineralization, where we're replacing minerals lost from the tooth surface. This forms a surface veneer containing fluoroapatite, which has a much lower solubility than the original tooth mineral. The pH at which tooth mineral dissolves is 5.5. When the mineral is converted to fluoroapatite, the pH at which it dissolves is lowered to 4.5. This makes, therefore, fluoride makes it more difficult for the acids produced by karyogenic or decay-causing bacteria and plaque to demineralize the tooth structure and cause dental caries. The highly acidic foods and beverages that contribute to erosion are citrus fruits, sodas, and wine. Erosion differs from caries in that bacteria are not involved and most of the mineral loss is at the surface. Some medical conditions cause erosion of the teeth by causing stomach acid to enter the mouth. Examples being acid reflux, anorexia, bulimia, GERD. This figure shows erosion from stomach acid. Please note the severe loss of enamel and dentin from the teeth due to the chronic vomiting. Fluoride provides some degree of protection against erosion, but repeated acid attacks will overcome the beneficial effects of a fluoride. And if you really look at this picture, you can even see the layers of the teeth. So here we've got the enamel, that white band right there, the more yellow looking areas, the dentin, and this person you can even see the pulp chamber here where that's located. It looks like it's even exposed on this tooth too. Although the fluoride ion has been shown not to cross the bacterial cell wall, it can travel through it in the form of hydrofluoric acid. As the decay-causing bacteria produces acids during the metabolism of sugars and cooked starch, some of the fluoride present in the plaque fluid combines with hydrogen ions to the acid to become hydrofluoric acid and rapidly diffuses into the cell. Chlorhexidine gluconate is a bisbiguidine, sorry guys, I can't pronounce that word, that is affected against a broad spectrum of microorganisms. In the US, the maximum concentration allowed by the FDA is 0.12%. It is a prescription mouth rinse that is available commercially through several companies. This is basically Paradex. I can't remember exactly what we have in the office, but or in the clinic there, but I know in my office it's called Paradex. Chlorhexidine kills bacteria by binding strongly to many sites in the oral cavity, including the membranes and plaque, and it is released slowly, giving it a prolonged effect called substantivity. Another word I can't pronounce, guys. The side effects associated with the product are the formation of a brown stain on the teeth, tongue, and composite restoration. It has a bitter taste and may affect the taste of some foods. So a lot of times you'll get some patients in the chair that have been prescribed this. Recently, we've been seeing, patients that don't drink tea or coffee and they're not smokers, they have this brown stain. We have come to realize that it's just from the prolonged use of chlorhexidine. So now a lot of places are, instead of using the chlorhexidine, we'll use it initially, and then once that first bottle is gone, we'll get them on something called Closis, which has similar effects to it. So supplements come in the form of tablets, drops, or lozenges, and they are prescribed by a dentist or physician. Gels and foams are applied for 4 minutes in disposable trays. Fluoride varnishes are applied directly onto the surface of the teeth, and they stay on the teeth for 1 to 3 days if the patient brushes gently. Self-applied fluoride gels and paste are recommended for individuals who are at high risk of dental caries and orthodontic patients to prevent caries and decalcification around the brackets and bands. Patients using an over-the-counter rinse are instructed to rinse for 30 to 60 seconds, spit out the excess, and to not eat or drink anything for 30 minutes. So safety, we have to make sure we use this as directed and keep away from small children. If any of you have small children, or if you remember when you were a kid, a lot of children will put the toothpaste with fluoride on the toothbrush, put it in their mouth, swallow it, and then put the toothbrush back and call it a day. So they're not even really brushing their teeth. So this is where we come in, why we don't recommend very small children to use regular toothpaste. We tell them to either use an unfluoridated toothpaste or just wait till they're a little bit older. The lethal dose for children weighing 20 pounds is approximately 700 to 1500 milligrams of sodium fluoride. On page 102 in your book, this is a nice chart on frequency of use and the precautions. Sealants. These are something that you will be doing quite a bit, depending on what office you're in. So sealants are used to seal the non-carious pits and fissures of deciduous and permanent teeth. The widespread use of fluoride has caused a significant reduction in dental caries in children who receive dental care. The greatest benefit from fluorides has been seen on smooth enamel surfaces. Most caries, about 88% in children, is found in the pit and fissures. The pit and fissures are often deep, narrow, and impossible to reach with the bristles of a toothbrush. These areas then collect food, debris, bacteria, and this begins the demineralization process. Sealants provide a conservative means of protecting pits and fissures by preventing debris, food, and bacteria from settling in these areas. When a sealant is placed early before cavitation has begun, it provides an effective barrier. If caries are sealed over, typically the caries process is stopped because a food source is no longer available to continue the process. If the sealant is poorly placed, the margins could leak and the caries process could continue. In this figure, the figure in this section of tooth showing a long, narrow fissure containing debris, a sealant is present and covers the opening of the fissure. So you can see right here, that's where the decay has started, and this right here is the sealant that has stopped that process from happening. But this is also why it's very, very important to make sure that the tooth does not become contaminated when we're placing these. Isolation is key. When selecting teeth to be sealed, consideration should be given to the age, oral hygiene, caries risk, diet, fluoride history, and tooth type and morphology. You'll want to seal teeth that have steep cuspal inclines and deep sticky fissures. Although the main thrust of sealant therapy is aimed at permanent teeth, primary molars may also be sealed to reduce the caries rate and prevent premature tooth loss. Doing sealants on children with primary teeth isn't necessarily a bad thing because they oftentimes have a hard time keeping their teeth clean. Unless the parent is going in after and brushing for them, you'll do sealants on children quite a bit. Polymerization of the resin occurs during either solely by chemical reaction, which is self-cure, or by light activation, a light cure. Many manufacturers add very small filler particles to the sealants to make them more wear resistant. Some of the filler particles used in sealants may be radiopaque and may allow the sealant to be seen on x-rays. So sealants are similar to the composite resin used for fillings, but they're more flowable. They're not as packable as a normal resin is. The self-cured sealant polymerizes to final set within approximately 2 minutes from the start of the mixing of the two components. When the material is light cured, the operator can manipulate the material at will. Light cured material requires a 20-second application of the curing light to each tooth or surface to which the material is applied. Manufacturers provide sealants in a variety of colors, ranging from clear, amber, tooth-colored, or opaque white. They even now make one that goes on pink, and then when it's light cured, it turns white. So this way it gives you a better view of where you're placing the sealant material. The clear material is very difficult for the dentist to see once it's placed. Unfilled sealants will wear faster than filled sealants. Wear typically is not an issue if the sealant is placed properly, since it goes down in those deep pits and fissures where the patient is occluding, it can't wear away that area. So sealant placement, this requires attention to detail. The technique has many steps. The surface of the tooth must first be cleaned with pumice to remove any surface debris that would interfere with acid etching or bonding. You want to use pumice and not the prophy paste, because prophy paste has essential oils in it, or an oil in it, and that can interfere with the bonding of the sealant. Acid etching roughens the enamel for penetration of the resin sealant. Studies have shown that application of an enamel bonding resin prior to placement of the sealant enhances the retention and seal. The cured sealant will have a very thin film of uncured resin on its surface. This film is called the oxygen or air inhibited layer. It should be wiped off with gauze or a cotton roll. Isolation during placement is key to success of the sealant. Any moisture on the tooth can result in failure. So you can look at procedure 7-2 on page 113 in the textbook. This goes over how to apply a sealant. Excuse me. There's also, I posted a YouTube video on how to apply sealant, so make sure you watch that before we start doing this in the lab portion of class. So causes of tooth sensitivity. This is usually due to exposed dentinal tubules. When they feel it, it's usually to cold fluids or air, sugar, acidic foods, and also exposed root structure can cause sensitivity. Teeth may become sensitive when the gingiva is receded and the dentinal tubules are exposed. Stimulus fluid enters the tubules and can cause irritation to the pulp. Desensitizing agents are used in several different ways. They may be used at the time of placement of a restoration, after a prophy or scaling and root planing, or for teeth with gingival recession and exposed root surfaces that are hypersensitive to touch or temperature. There are various desensitizing agents. A lot of them that we recommend is usually a sensitive toothpaste. Fluoride helps with sensitivity. Resin primers and bonding agents, they make a material that is specifically meant for desensitizing called Gluma. And what that does, that kind of blocks those dental tubules openings and prevents that fluid from going in and out, causing that irritation. Another thing with sensitive toothpaste I want to touch base on is a lot of patients will say that, yeah, I use sensitive toothpaste and it doesn't work. You have to consistently use the same sensitive toothpaste. Each toothpaste uses a different ingredient to block those tubules, and it needs time to build up. So if they're switching from toothpaste to toothpaste, it needs that time to build up on the tooth in order to work. So I always recommend stick with the same kind, give it a couple of weeks for that to build up on the tooth, and they shouldn't have as big of a problem. Remineralization is the process of repairing the surface of the tooth structure that has lost mineral because of exposure to dietary, environmental, gastric, or bacterial acids. Because tooth mineral is largely calcium and phosphate, products that contain calcium and phosphate can help replace lost tooth mineral. Resin infiltration is an approach to halt the progression of the early smooth surface white spot caries lesions. This is done by infiltrating the lesion with a low viscosity resin. The resin blocks the porosity in the enamel and prevents caries progression. In summary, preventive practices in dentistry can extend far beyond the normal cleaning and fluoride application every 6 months. Caries arrested in tooth structure remineralization by performing caries risk assessment and using topical applications of fluoride can help. We do sealants to protect the pit and fissures and also prevent the higher risk patients from getting decay. Desensitizing agents are important because people can retain their teeth longer, and this will give them hope that things can change. So if you guys have any questions over the material covered in this chapter, please feel free to reach out to me. My email is hwells14@ivytech.edu.